Good day. Today we're going to begin our lectures on the digestive system, and we're going to study how food is ingested, prepared, transported through the body, and then broken down by digestion and absorbed and finally excreted. Long, complicated process. We are by nature and evolution omnivores, though some people choose to be vegetarians or one kind of an eater or another. We are equipped and have evolved as an omnivore with wide ranges of abilities to digest different foods. I'm going to start with an overall look at the digestive system. Here's the whole body, and what you might notice is if you look at this carefully and look at the mouth, esophagus, stomach, small intestine, colon, and finally the rectum and anus, the digestive system is literally, though unromantically, the tube that starts at your lips and is unending and continuous right to the anus. Now, this started embryologically as a simple primitive tube. If you look at the first part of this slide, this is the embryo in the very earliest stages. And this is the primitive gut going along here. The heart and the upper end or mouth will be up at this end of the embryo, and the rectum will be at this end of the embryo. Later on, things to develop. Here's the spinal cord developing. But again, the heart is in a primitive state, and this gut tube is moving right along as a straight, hollow tube. As things progress, other organs begin to get bigger. The heart at a later stage is quite big, while the embryo is still quite primitive. And the tube now is beginning to show a widening in the pharynx, which you've already seen. And it's going to get some little outpatchings. It's going to still end up at the anus down here. But finally, some buds are going to come off here. For example, the pancreas. And we're going to see other outpouchings appear on the body for connections with the liver, as I said, the pancreas, and other organs that are part of this system. Also, we're going to see widening and narrowing and rotation of this tube that'll ultimately go back and look like this. So we'll have an opening in the mouth, a long, narrow esophagus, a rather odd-shaped stomach, and then a squiggly and long small intestine, and a twisted and replaced and positioned colon and anus. Today we're going to start and just make a geographic tour and go from one end and stop just at the end of the stomach. And then we'll go back on another lecture and look at the physiology. Basically, we have roughly 40 feet of length between the lips and the anus. It's a long way. Even though we're only a few feet in length at that part of our body, there's a lot of coiling to make it suitable for absorption and transport and the time necessary to get digestion of these elements. The body or the digestive system actually starts at the lips, which are used to take food into the mouth, and the tongue, one of the biggest muscles in the mouth, which is used to move food around and position it for chewing. The tongue also has sensory organs. The tongue has lots of sense. It's one of the special sense organs that has taste buds all throughout its upper surface. Here the tongue is pulled up in the mouth, and some of the obvious things that don't need much comment are the teeth, with the grinding teeth in the rear and the biting, nipping teeth. We have what are called canine teeth here, which tend to be a little longer and remind us of our origin with the predator animals. Further back in the mouth and is this arch, which is very familiar. This little organ is called the uvula. This detects the passage of food and signals the raising of the back of the palate, the roof of the mouth, which is soft. It's called the soft palate. It does not have bone in it in the rear 1/3, and this part of the palate can rise up and prevents food from going up into the nose, into the nasopharynx. Behind this arch, this is called the palatine arch, and sometimes called the palatoglossal arch because it goes down to the tongue. Behind here are some tonsils, which carry lymphatic tissue, our infection-fighting tissue. And we'll see that in places all through the body. And there's also a palatopharyngeal arch in the back, right here. And between the two lie the tonsils. Also tucked back up in here, right about at this point, is the end of that eustachian tube. We saw in the last lecture that we talked about the hearing, and it decompresses into the mouth. The entire mouth is covered with what's called a mucous membrane, and these mucous membranes are to give lubrication and allow us to swallow and chew things without irritating the surfaces of our mouth. Now, also in the mouth are 3 sets of salivary glands. They're paired, they're on each side, and they secrete saliva, which is the first step in the digestive process. This takes place right in the mouth. The saliva is not only for lubrication and to moisten the bolus of food. You'll hear me use that term a lot. The lump or wad of food that we're going to swallow is called a bolus. We have a very big gland here called the parotid gland. People say that's because it makes us look like a parrot when it's swollen. I believe the origin really is para-otid, near the ear. It's right in front of the ear, and it has a duct which pierces the muscles and goes right into the mouth inside the cheek. There are 2 more sets of glands, one submandibular under the jaw and another set sublingual. These glands enter the mouth with little ducts, and they provide enzymes that aid in digestion. The salivary glands moistens the food as it goes down. There are some enzymes which kill bacteria and also may dilute poisonous substances. We, as surgeons and doctors, have a maxim that says the solution to pollution is dilution. And in all kinds of systems in the body, you're going to see that the body responds by trying to dilute things it doesn't like. That's the origin of swelling. Same thing in the mouth. We use a lot of fluid there to try to dilute some of what's coming in to make sure it's not toxic. We put out approximately 1 liter to 1.5 liters of saliva a day. That's a lot of saliva, almost 1.5 quarts throughout the day. And it helps in dissolving food and getting some of those molecules into solution so that we can perceive taste against the taste buds of the tongue. Now, most of that saliva is water, and it's almost all reabsorbed in the gastrointestinal tract unless you're actually spitting. I might mention the parotid gland once again, which is over here in the cheek. This is the location of infections of the mumps virus. You know, most of us are starting to forget about that now because we have vaccines against mumps, but the virus likes to live there. We used to diagnose mumps by giving somebody a pickle to chew on. It would make the gland contract, and that would be very painful. Mumps also affects the ovaries and the testes. The swelling is not significant except in the case of the testes, where it swells in a confined space, can actually cause sterility. It doesn't happen with mumps in the cheek because there's lots of room for expansion. Now, we come across our first enzyme in the mouth, and that's called salivary amylase. The ending ASE depicts an enzyme, and all the enzymes end in ASE. Salivary enzymes break down the carbohydrates. There's another substance called lysozyme, which can kill the bacteria in the mouth, and there's lots of electrolytes and ions, such as bicarbonate, which is a buffer. There's chloride, which activates the amylase as it comes into the mouth, and there's some phosphates in the mouth as well. So a lot of digestion is beginning here, and this lipase, lipo refers to fat, so this is going to break down fat. And lipase, again, is secreted by all 3 glands. It breaks down triglycerides into monoglycerides. The amylase that I mentioned earlier breaks down carbohydrates. This is a triglyceride, and I'm going to talk to you a little bit more about this later, but basically you have a glycerol molecule, and it is attached normally with an H and an OH, which can be broken off to make water, H2O. In organic chemistry, we define biologic or organic chemistry on this planet by the presence of it being a carbon-based chemistry. Look at all the C's. This is the carbon atom. And attached to those are hydrogen atoms. And often in ratios of H2O, that's why they're called carbohydrates, because they are in the ratio that hydrogen and oxygen appear in water, 2 hydrogens to an oxygen. When we have the molecule with 3 fatty chains here, we have a triglyceride, and that starts to be broken down in the mouth. During dehydration, the brain senses the absence of saliva in our mouth, and it will do something. It will stop the flow of saliva to our mouth so that we don't feel better about it. Dehydration is a signal for us to drink. We don't like that feeling. So when the brain sees that the osmolarity, the concentration of solids and fluids is tending toward the side of dehydration, will stop the flow of saliva, in part because it doesn't want to lose that liter, but in part to make us drink more and get rid of that feeling. You might remember Pavlov, the Russian physiologist who trained his dogs to salivate. He would ring a bell and feed them, ring a bell and feed them. Finally, he could ring that bell and the dogs would salivate in what's called a conditioned response when they just heard the bell, when there was no food present. We're actually not much better than that. We will do the same thing. You can walk into a restaurant, smell the delicious food if you're hungry, find yourself salivating and occasionally, unfortunately, drooling. So that's the mouth and the salivary glands and some of the enzymes involved with the very earliest stage of digestion. This is a very quick passage. Most of us make it quicker than we actually should. We don't chew the food enough. We swallow too quickly. This is our high-speed society. We get the bolus moving down into our esophagus actually before it's ready. But the system is very adaptable. Now, if we move on and look at the next slide, we have a picture here of the bolus in the mouth. This is known as here's the little wad of pictured bolus. During this stage, we have what's called voluntary swallowing. We chew, the tongue will move the bolus back in our mouth and upwards toward the palate and then down into the pharynx. As the food passes from here in the back of our throat, and by the way, look at the size of the muscles of the tongue. You know, we just see the surface, but it's an enormous organ relative to the size of the mouth. The bolus slides down and past into the upper digestive system right above the esophagus, and this now becomes totally involuntary. There's no control that you can do to make it go faster or to slow it down. You remember now, too, that the epiglottis will fold back and the larynx will come up to meet the epiglottis and close off the airway and make sure that the bolus slips past behind the trachea and not into the trachea, where we might have aspiration and possibly death. So the bolus goes down through here, and it passes through several kinds of constrictor muscles. Now, there's a whole series of muscles in the upper part of the esophagus and the lower part of the pharynx. There's an upper, a middle, and a lower constrictor, and they each squeeze as they move the bolus down. It's an active process. It's not dependent upon gravity. And it's very highly coordinated. There are many disorders of swallowing which make this a problem, so that people either aspirate or feel the food held up, and usually neurologic disorders. Immediately after you swallow, while the bolus is still high and near the larynx, breathing stops for about 2 seconds and automatically resumes. Again, you probably don't know that. but it happens automatically and unconsciously. Next thing that happens is the bolus is going to move down the back of the esophagus. And the esophagus is just a long tube passing from the lower neck, and it goes all the way down where it connects with the stomach. Now, one of the things you may want to look at to get an idea of the position in the whole body, this is the body open in the front. I have removed the liver, which takes almost the whole upper right quadrant, and this is the stomach. The esophagus pierces into the abdominal cavity very near the back. This is the end of the esophagus. So the whole stomach and only a little bit of the esophagus should be in the abdominal cavity. We call the space between the diaphragm and the pelvis the abdomen, not the stomach. Stomach is an organ. So in the abdominal cavity, we have the piercing of the esophagus, and I'll tell you a little bit more about how sometimes that is not always the case. If we go back to this slide, what we'll see is there are several portions of the esophageal stage. There are two kinds of muscles in the esophagus. There are longitudinal muscles that run down, and there are circular muscles that constrict right here. What happens is the longitudinal muscles pull the esophagus up and relax the lower segments, and then the circular muscles constrict here, moving the bolus down and down and into the stomach. I want to make one small digression to tell you something about the structure of the esophagus. Do you remember the preparation and the enveloping of the heart and the lungs and the brain and the pleura, the parietal and visceral pleura, the parietal and visceral epicardium? Now, if you look at the esophagus, it is separated in the mediastinum, in the middle of the chest, from all those organs. It never got covered with any kind of tissue like that. That tissue recurs again in the abdomen. I'll go over that when we get there. But the esophagus is bare on its outer wall. Every other organ has a very thin layer of cells, like the stomach has cells here called the serosa. Serosa is very strong. It is the equivalent of the visceral pleura and the visceral epicardium. But we don't have any of that in the esophagus, and it's of significance because it makes surgery on the esophagus very difficult and very dangerous, because there's not a good place to put your stitches or your staples. There is very rapid passage of water as it goes through the esophagus, usually in about a second or so. Food may take 5 to 9 seconds. Now, as the food slides down there, we're usually not aware of anything happening. In normal swallowing, we feel the swallowing as it gets to the back of our throat, and then it kind of disappears. If the food is very hot, very acidic, very cold, or very dry and rough, we sometimes can feel that sensation going through our neck. However, going through our chest. However, most of the time we feel nothing. Spicy foods, for example, you'll generally feel on your lips, on the back of your throat, and on your tongue. Usually, unless you have an irritation or inflammation of the esophagus, you usually don't feel any of that going down into the abdomen as it passes through the mediastinum. Now, coming back to the slide, at the bottom of the esophagus, where it joins the stomach inside the abdomen, is something called the lower esophageal sphincter. It's not an anatomic sphincter. There is no special muscle that we see there. It's what we call a physiologic sphincter. It is an area of the normal junction of cardiac muscle and esophageal muscle which contracts tightly when food is trying to get back up into the esophagus from the stomach. It prevents what we call reflux of acid, of bile, of food into the esophagus, and it's the site of a lot of pathology. There's something called achalasia, which is a failure to relax, so people can have spasm of their lower esophageal sphincter and be unable to get food down into the stomach easily, and they feel fullness in their chest, difficulty and maybe even pain when they try to swallow. More commonly, and surely something you can't have missed on television, is something called GERD, gastroesophageal reflux disease. Very, very common in our society and throughout the world to have a failure of the sphincter to prevent reflux. And acid and bile can wash back up into the esophagus, which is very, very poorly protected from this kind of event. So the esophagus gets inflamed, it can get strictured with scarring after a long time, and it can even be a cause of certain cancers of the esophagus. There is a disease of the esophagus in which there is gastric mucosa, the gastric lining, up in the esophagus. It's called the Barrett's esophagus, and those patients, if they have atypical cells, have a very high incidence of cancers of the esophagus, which can be very, very hard to cure. We also have hiatal hernia, the hole in the diaphragm through which the esophagus passes should be very tightly wrapped around the esophagus. It's not always the case. Sometimes that hole widens, and the stomach, because of the abdominal pressure and the negative pressure in the chest, can be forced up into the chest. So if you look at this area again, I'm going to remove this patient's heart. You can see the diaphragm here. You can see the back of the diaphragm as it curves this way, and here's the esophagus poking through. Look what was sitting right up here. The heart was sitting there, and the lungs, and back of all of it, you can have this hole widen, and the stomach can actually move right up in the chest. Here's the esophagus up here, and this whole thing can shorten and be up in the chest, making that reflux worse. We used to have a lot of surgery to treat this, and one of the interesting things is we had 4 operations named after 4 doctors. There was Allison, Hill, Nissen, and Belsey. All got operations named after them. It tells you something. When there's 4 operations, it means none of them are any good, because if there was one operation that worked, we'd only use that one. Well, they improved the Nissen, and they made it so we could do it without opening the abdomen. We now do this laparoscopically and wrap the 2 sides of the stomach together to make a new anatomic valve to prevent reflux. Better than that, we have now developed substances which are called proton pump inhibitors, which markedly depress the amount of acid produced by the stomach, and they work much better than antacids, for example, and these have revolutionized the care of the hiatal hernia patient or the patient with GERD. These patients take 1 pill a day, they don't produce any acid, and what washes back up into the esophagus is just water, and it doesn't irritate the esophagus, and these patients almost never need surgery. They can go decades now, we find, on this medication without any problem. That's the esophagus and its entry into the stomach. Let's take a look now at the stomach itself. People tend to think of the stomach as a big hollow organ, and it is hollow and it is big, but it has compartmentalization. It's basically an enlargement of the gastrointestinal tube, that long tube, that happens just below the esophagus and just below the diaphragm. And not only does this tube enlarge, and it enlarges in this anterior-posterior diameter, it also twists. It turns itself to the right. So now what was on the left is now in the front. You may think, of course, so what? It matters to the surgeon. It matters to us because the way it lies in the abdomen takes nerves that were on either side, the vagus nerve, which you've heard about, and rotates them front and back. So when we go to look for those nerves, which we used to do in surgery because they needed to be cut sometimes, we knew not to look on the right and the left, even though they're called the right and left vagus. We need to look front and back. So the knowledge of embryology tells you where things are going to be and why they're in that position in the abdomen. The stomach's function is to begin the mixing and digestion of food and continue what went on in the mouth. The esophagus function was purely conduit. It just brought the food down into the stomach. No digestion took place in the esophagus other than what was already going on with the salivary amylase for sugar and lipase for fat. Food now arrives in the stomach. We have this massive enlargement compared to the esophagus, and it ends up having 4 main functional divisions. There is an area right below the esophagus called the cardia. Why? Because if we go back over to our model, we can see that this portion of the heart lay right below, this portion of the stomach lay right below the heart. And so that was called the cardia, just named for its nearest neighbor. We also have an enlargement at the very top of the stomach called the fundus. The top enlargements of certain organs are called the fundus. There's a fundus in the gallbladder, and there's a fundus on the uterus. So that's the top 2 sections of the stomach. And then we have this big area here that's called the body of the stomach. And finally, the antrum. Now, the antrum of the stomach, again, it's a waiting room. It actually means a cave. And it's the last part of the stomach before the pylorus. This area is called the pylorus. It's a very thickened muscle. If you look quite carefully here, you can see that the outer muscles of the stomach become thickened to form a true anatomic sphincter, which remains closed. Pylorus means the guard gate. And it prevents food from entering into the small intestine until that food is ready and until the intestine is ready. The intestine has to be cleared and prepared for the passage of food, and the food in the stomach has to be in its proper composition and stage of digestion before the pylorus will open it and let it in. So when food enters the abdomen, it doesn't just dump into this big cave. It lands in the cardia. It remains there for a while. It then gets ground up a bit right here in the fundus and moves along where it's continued to be mixed and ground up, and then it moves on to the antrum. The muscles of the stomach, as you can see, starting here, and this is a stripping from the near side. So we've stripped off the serosa, which carries the blood vessel, and as I mentioned, is like the visceral layers of the other organs. We actually call this the visceral peritoneum. Here's the first layer we come to, the longitudinal layers, and then the cut edge shows that beneath that we have some circular layers, and then some oblique layers, and then down here in the antrum, we have something called the rugae, or folds. And this is inside the stomach, facing us from the back. The purpose of all this is so we can get a grinding and a twisting and a moving of all this material so that it's very, very well mixed and broken and mashed up down at the level we needed for entry into the pylorus. A word about the pylorus. This little area, which guards our entry, is the source of a very interesting problem in infants. In an unusual group of infants, the firstborn male child of some families, including mine, has something called pyloric stenosis. You now know stenosis is tightening. The baby gets a very small thickening of the pyloric muscle, a hypertrophy. It's actually called hypertrophic pyloric stenosis. The muscle builds up to tremendous size and strength after birth. And so at birth, the baby looks perfectly normal. The pylorus is normal. And over a period of about 6 weeks, this stenosis increases, the hypertrophy increases, baby starts vomiting. Pretty soon, the baby starts losing weight because it's not keeping anything down, and the vomiting is called projectile vomiting. When a doctor sees a firstborn male child with projectile vomiting at 4 to 6 weeks, the diagnosis is made. The baby will actually shoot the formula or milk across the room. There's that much force of contraction. And it's a beautiful cure. You take this little infant and operate through a tiny little hole in the upper abdomen. You don't have to make a very big incision because you can pull the pylorus up. It's called the olive. Feel the baby, you can feel this little olive inside. Pull it out on the skin, and you just use a small knife to cut down and divide the muscle fibers of the pylorus spread them apart a little bit with another instrument that looks like a mini golf club until you get to the lining that covers the inside of his passageway, and you don't cut that. Just cut the muscles. An experienced surgeon can do this operation in about 20 minutes. It's all over. There's no bleeding. The baby doesn't lose a thimble full of blood. You drop the olive back inside, sew up the abdomen with a couple of stitches, and hand the baby to the mother. Baby wakes up, mother can start feeding the baby, and she's got back her precious child who's now eating, and in a few weeks will regain all that weight. It's just a wonderful piece of physiology and cure, very rewarding thing to do. It's one of the most wonderful things we get to do as surgeons. That's hypertrophic pyloric stenosis. Moving on now to the stomach and its functions. A lot of digestive processes take place in the stomach itself. If we take a look at a cut through the mucosal wall of the stomach, and it's a little different at different layers, but we've put all the cells here in one place. What we see is the mucosa lining the whole cavity. It's called mucosa because it has mucus on it. It's a very rich, thick, plush lining that looks like a wet velvet. It has many kinds of cells and many folds of a gross nature, and then microscopic folds which pile up to increase surface area. This allows for more excretion and contact with the food. Now, almost nothing is absorbed in the stomach. This is a digestive organ that secretes things to do digestion, but doesn't absorb anything. Absorption occurs further on down the intestinal tract. What happens here occasionally is you can get absorption of water, and you can get absorption of alcohol if the patient is dehydrated. So that's one exception. The mucosal surface has, if you look at the next slide, on close-up, very, very deep clefts between the layers of mucosa. This increases dramatically the surface because you can see if you had just this amount of surface, you'd have so many cells, but if you multiply it probably 20, 30, 40 times and maybe more by going down into those deep clefts. Then there comes a layer of the muscularis mucosa, which helps move and protect the mucous membranes. In the layer below that is where the blood supply runs. Then we have all the different layers of our muscle, and finally the serosa on the outside. Let's take a look at just one of these deep clefts. If you want to see what it really looks like under a microscope, we can move down here. This is what the surface would look like with that pit representing this little opening up here. Here we have selected one gastric pit to look at. Submucosa, muscularis mucosa, some smooth muscle fibers, but basically it's what we call our gastric glands. Now, one of the most common glands in this body are the mucosal cells themselves. They are called the mucosal neck cells, and they look like this. They're scattered at various intervals, all up and down, and they produce a glycoprotein, means a sugar and a protein together that's greasy to the feel, covers the surface, and is found all through the body and protects the stomach from digesting itself. The stomach is, after all, meat, and we don't want it to digest itself. One of the most important cells is the parietal cell, which looks like this, and it will be seen here. The parietal cells secrete hydrochloric acid in the form of hydrogen ions, and they also form something, secrete something called intrinsic factor, which helps absorb vitamin B12 further on down in the line. Now, the parietal cells are only located in the fundus and the body of the stomach. We have no parietal cells if we go back to the antrum down here. There's a reason for that, which I'll get to in just a moment. So if we go back to this slide of the crypt, We have our primary important cell here is the parietal cell because it secretes the very important acid that does several things. The acid breaks down a lot of the components of our food, and it provides a very unfriendly environment for bacteria and foreign invaders. The next cell of interest is called the chief cell. It looks a little bit like this. Very metabolically active cell, and the chief cell produces pepsinogen, which is a precursor to pepsin. Why does it produce pepsinogen? Gen means it generates pepsin. Pepsin is a proteolytic enzyme, breaks down proteins. We don't want this working inside the wall of the stomach. We want it to get activated, so it'll come out in an inactive form and later be activated when it's needed. We also have gastric lipase coming out of this, another enzyme again, which in its form digests fats. We no longer have the salivary lipase working because the pH has changed. The mouth and the stomach have a different pH. Stomach has a very low pH. It's very, very acid. Concentrated stomach acid can eat through a lot of things, including itself in pathologic states. Finally, we come down to another cell called the enteroendocrine cell, sometimes called G cells, and these are located down in the antrum. Entero means intestine. Endocrine is a cell that puts out a hormone that is secreted into the bloodstream. This is not an enzyme. Enzymes end in ASE, lipase, amylase. The hormones end usually in IN, like gastrin, adrenaline. These are signalers. This is not squirted out through the gastric crypt into the stomach, but this is picked up down in the blood vessel area here and taken to the rest of the body. But the place it's taken primarily is it circles back around and it goes to the stomach from the antrum through the bloodstream, not through the lumen, and stimulates the parietal cells. So when the antrum gets signals that more acid is needed, which usually is caused by one of two things: distension of the antrum, meaning expansion of its walls, is telling the antrum, I've got too much food down here, I need to break it down. So it sends a signal to the parietal cell to give me more acid. The other thing is if it starts sensing a rise in pH. If it's getting more alkaline because the food is absorbing too much of the acid, it will also signal the rest of the stomach to secrete more acid. In the old days, when we had a patient with an ulcer in their duodenum from too much acid, we did not take out the acid-secreting cells. We did not go back up here and take out the place you would logically want to take it out, just get rid of the acid, because to hook the intestine up to the esophagus was very, very dangerous. We couldn't do it easily. Instead, we went down and we just took out the signal. We took out this antrum part of the stomach, which was very easy to connect up, very safe, and we took away that signal. We also cut some nerves to the stomach, which I'll tell you about later. That was before we had these wonderful inhibitors that stop acid with just a pill instead of a big operation. So that's the main function and structure of the stomach part of this digestive tract. So if we look at it, we've really got basically breakdown, chewing, grinding, mixing, and then the secretion of enzymes and a hormone, which will signal more enzymes to break down this mass into something that the rest of the body can tolerate. The duodenum in the small intestine is very, very small. It can't really take huge masses, and it needs small, well chewed up, ground down system of components before it can do anything further. Another interesting fact is that we have this big stomach, and we have this kind of system, which, as I said, has been evolved for omnivores. We are predators. We've arisen from predators. Predators and prey animals have different digestive tracts. Our digestive tract is designed to take food at big intervals. We take a big meal in this huge organ, spend a lot of time preparing it for entry into the rest of the tract, but during that time, we can go out and do something else. We can sleep, or we can hunt, and we can find another prey animal. Lions who eat a big meal will often sit down and not eat for a couple of days until that's all gone. We tend to eat more frequently, but the same principles apply. We don't really need to eat any more frequently. We're able to go out and hunt and spread the time to do other things. Prey animals are eating all the time and digesting all the time, and they almost never rest. It's a major difference in our systems. It is a requirement of that system that they continue to eat, because they don't need to hunt. They just need to run away. Okay, let me get you to the blood supply. I said we would be returning to the blood supply frequently, and that's why I didn't go into detail when we studied the whole vascular system, because I thought it would be more appropriate when we get together. This is a picture of the abdomen from the front. Something funny is going on right here. The stomach looks peculiar. What the artist has done is taken the stomach, a little artistic liberty, and raised it up like that. You can't do that. You can't do that because the stomach has a big fat apron full of blood vessels that comes down all the way to the bottom of the abdomen, fuses, and comes back up and inserts right along there on the colon. You couldn't pull this up and away. It wouldn't go without cutting it. That apron is a very important organ, and this is a good place to mention it. This is called the omentum, which means apron in Latin. It's a real organ. It looks to us just as if it's fat, and it looks like blood vessels, but it is, to the surgeon, the guardian of the abdomen. When you get something going wrong in the abdomen, a ruptured appendix, a perforated duodenal ulcer, bleeding, any inflammation or irritation makes the omentum, which is normally very slippery, very sticky. And so the first thing that happens is the omentum will stick to the ruptured appendix. It will stick to the perforated duodenal ulcer, which is spilling peas and steak out into the abdomen. We'll go in and operate on that patient and find the omentum stuck there and plug the hole. And in fact, once we've made the diagnosis, we'll just sew the omentum there so it can't come away, clean up the abdomen. Knife wounds. Sometimes you'll go to see a patient with a knife wound and you will find the omentum sticking out the hole. It has plugged up the hole. We don't like to take the omentum out. It's a very important organ. It's also a place that gets involved in certain cancers, such as ovarian cancer. Very easy for those to spread to the omentum. The omentum tries to hold it in check. It's something we hardly ever think of as an organ, but it is, and it functions. It's quite important. Now let's look at this blood supply. The stomach has been flipped up, so we're looking at the bottom side of the stomach. Just inside the lower portion of the back of the diaphragm, actually next to the esophagus, which is here, is something which is called the celiac trunk. It gives off a bunch of vessels, a very, very big vessel here called the common hepatic, which gives off a right gastric vessel. It also gives off a left gastric vessel, and look how they join in an anastomotic loop. So blood can flow from either side to the stomach. It gives off a gastroduodenal, stomach and duodenal vessel, which gives branches down here. It too goes on to the opposite edge of the stomach and comes around the side where it joins some other vessels. Here is a big, big artery going to the spleen called the splenic artery, and it gives off short gastric vessels, which are the bane of the surgeon because they're so easily torn and they can bleed massively. We're very careful not to tear those. And they join up with vessels both on the top of the stomach here and the bottom side, which is inverted, so that we have this huge loop of interconnecting anastomotic vessels supplying the stomach. The blood supply to the stomach is so rich and it's virtually impossible to devascularize it. One of the things we're not careful about when we do surgery on the stomach is preserving the blood supply. We take what we need to get the job done, and we worry more about controlling bleeding and not taking too many vessels as we might have to somewhere else. In fact, at one time my predecessors thought, years and years ago, in the middle of the last century, that you could control ulcer disease by cutting off the blood supply to the stomach. and they found they couldn't cut off the blood supply to the stomach. If they had any left, the blood supply went on and helped the stomach produce acid. If they cut too much, finally, you would kill the whole stomach. So it was a nice experiment, but it really didn't work. The supply is very, very helpful. It's a real survival factor, but it's also a two-edged sword because bleeding from the stomach can be very, very serious, in fact, life-threatening. That takes us through from the lips to the duodenum. Next time we'll take a look at more of the physiology and the anatomy as well.